Now, from the News Channel 5 Network, this is Medical Mondays.
Hey there, everyone. I'm Jessica Ralston. Welcome to Medical Mondays. And if you're feeling any sort of pain, you want to make sure you stick with us for the next hour. We want to welcome back Dr. Yelameli is here from the Nashville Pain Center. And he can take your calls and your questions about any kind of pain that you're having. And explain first, let's start talking about the Pain Center, exactly what you treat there. I would assume you do a lot of neck and back.
Yes, that's the main, the most common problem when it comes to chronic pain. But we treat all different types of chronic pain that can happen to a person in this clinic. And we use multiple modalities. We use medications, which are controlled, non-controlled, which are, and procedures. We use procedures. We basically use the services of other specialists also as needed. We can refer patients out for psychological support. We can refer them for psychiatric support, physical therapy. And we also refer patients out to other surgeons like orthopedic surgeons, spine surgeons, neurosurgeons. We use all the other specialists also in managing the pain of a patient, which can be of any cause.
Tell me the difference between, I guess, regular pain and chronic pain. How do you know when you have a serious issue, not just a kind of routine backache situation going on?
You're right. Correct. Chronic pain means a pain that lasts more than 3 to 6 months.
Wow.
And any pain that has already been addressed, completely investigated by other specialists, and all necessary treatment has been done. Let's say a surgery or any other modality of treatment that's available for that pain. And finally, they have come to a conclusion that there is nothing more that can be done. Patient continues to complain of pain. So this is chronic pain. And after like 3 to 6 months, typically, whoever specialist is treating that particular problem will say, I have done everything I can. This pain is just there, and it's not. There is no structural abnormality. We've already taken care of that. Let's say you have a slip disc. The disc has been taken care of, and you still have pain. So this needs to be managed by a pain specialist. And then they refer the patient to us. It can be an abdominal pain. It can be, let us say, endometriosis among women. They have undergone several surgeries for endometriosis, have all the treatments that can be done, and the patient continues to complain of pelvic pain or abdominal pain, and the gynecologist can say, okay, I've done everything I can, go and see a pain specialist. Similarly, a knee pain, osteoarthritis, the patient has already had a knee replacement surgery and continues to complain of pain after knee replacement surgery. So what do the surgeon do now? So the surgeon will take another X-ray or another type of imaging and say, it looks good, the surgery has come out well, everything looks fine, but you still have pain. Go and have your pain managed.
And then you have to start looking at alternate forms of treatment.
Correct. So we just start managing the pain. So this is chronic pain. Another type of chronic pain is, let us say pain starts, let's say in a 35-year-old person, he has a back pain today, and it gets better after a week, after some rest and just some non-steroidal anti-inflammatory drugs. After a year, he gets injured again, and it takes a little longer to get better. Third time, it gets worse. He has to do physical therapy. He has to go to the doctors. It takes even longer. So typically, over a period of lifetime, over a period of a decade or two, the pain can become worse as it goes. Every attack lasts longer and longer, and ultimately the patient may end up getting a surgery or some major treatment for that. That's also chronic pain.
Interesting. Okay, we already have a caller, but I have a question I want to ask you connected to all that right after we take this call. Hi, Danny. Thanks for calling in tonight. What's your question for the doctor?
Yes, I have a question. I had a car accident 18 years ago, and I suffered just about a complete break. And 18 years ago, I had a car accident.
And then what happened?
And I suffered some spinal fractures and neck fractures. And the one in the middle of my back, they're telling me, has turned into something called scoliosis. And they're recommending surgery, one of the neurosurgeons I have been seeing out of St. Thomas. And I'm wondering what other options are available for something like that.
So you have had some fractures in the spine, and the scoliosis has developed after the accident, right?
Yes.
And have you had any surgeries already on the back?
No, I've been putting it off and putting it off.
Okay. Is this causing pain?
Yes, I've been going to a pain management clinic for probably around 12 years.
And how are you being managed there? How is your pain being managed?
With pain medication.
Okay, so typically if you have had a trauma to the spine at any point in your life, it is possible that certain changes set in over the years. As we grow older, degenerative changes set in. The discs can get degenerated, osteoarthritis can set in inside the spine. There are multiple joints inside the spine on either side, which all can get arthritic. And you said you have also already developed scoliosis, which is also a part of a degenerative process. So the neurosurgeon, if he's offering you surgery, then probably the scoliosis is severe enough to impede your respiration, or it's causing neurological deficits, or he may be afraid that you may end up with some neurological deficits. That may be the reason why he is advising surgery. But it's always, if you want a second opinion, we can always take a look at your spine and see where the pain is coming from, and offer some injection procedures and see if you don't have to depend on medications alone, whether your pain can be managed better with medications and some procedures that we can add in.
Okay,
So
I've had the epidurals, steroid epidurals. I've had those done several times.
Mm-hmm.
And it seems like they last for like a short period of time, and then the pain comes back.
So the epidurals are done in the lower back. If you have scoliosis, is it in the mid-back area or is it in the lower back?
It's in the middle of my back.
So has anything been done there at that area, in the mid-back?
No, not at all. I've been, like I said, I've been putting it off because I've seen so many people that's had back surgery that come out with just as much pain as, after they have the back surgery as they did before.
So do you have any pain shooting down your legs, or is it just all in the back?
My left leg.
Okay, so the epidurals will typically help you with the shooting pain down the leg, but it won't help you much in the back itself. And we need to do other procedures we call facet medial branch block, we call it. Like we block the little joints in the spine that may be causing this pain, and help you with that. We have certain procedures that can make this relief last a long time. We've got something called radio frequency ablation procedure, which can make the relief that you're getting for a couple of weeks from a steroid injection last several months to a year. So we cannot just depend on an epidural injection for this kind of pain. We have to do a combination of epidurals and arthritis injections, which we call facet injections, and make it last longer by doing radio frequency ablation, wherein we just ablate the nerve that is supplying the joint, and that will help you with the back pain for a much longer period.
Okay, I really thank you very much.
You're welcome.
Well, thank you. Thanks for your call, Danny. All right, Marcia has been holding there. Hi, Marcia. What's your question? Are you there still, Marcia? Marcia, can you hear us? Okay, we'll check on her, and then we have another caller here too. Hold on one second. Lydia's called in tonight. Hi, Lydia. What's your question?
Actually, I don't have a question. Hi, neighbor. I just wanted to tell, because a lot of doctors don't get shout-outs for them, but I just wanted to let you know that he is an unbelievably excellent doctor.
Oh, thank you very much, Lydia.
Well, that was nice for you to call in and say.
I know how I am.
Yeah, no, if you go to that pain clinic, he will fix you as best as he can, because he's got me up and walking, so.
Thank you so much. That's so nice of you, Lydia, to take the trouble to call us. Thank you very much.
I saw you again. I'm like, okay, I'm hearing his voice again. Why?
Oh, that's funny. Well, awesome. Well, thanks for calling in. Thanks for the shout out. We'll take him anytime.
Okay. See you soon.
Have a good night.
Okay, bye.
Bye.
It was interesting. That's what I wanted to ask before you took that first call. It seems logical, I guess, when you talk about referring patients for psychiatric care, psychological care, that if you are miserable and in pain for such a long time, it has to have a psychological effect on you.
Correct,
I'm sure people get depressed, frustrated.
Yes.
And
it's very common. Yeah. Over a period of time, if you have severe, unrelenting pain for years and years, obviously it's going to affect your mood, you know, and mental makeup. So people start getting depressed. Anxiety is a very big problem among chronic pain patients. So we always make the use of psychiatrists. We always make sure that they are also involved in the care of the patient. Sometimes, as you were saying, if you just have a lot of medications to take and some epidurals, that may not be enough. We have to look at where else the pain is coming from. Why is he still complaining of pain? We may have to add in, as I said, there are so many other procedures we use, not just an epidural. And it has to be done at the right time. When a patient does not have shooting pain down the legs, there's no point in repeating an epidural again. Okay. It's better to do an injection which helps him in the back itself, which is like, as I was saying earlier. And there are other modalities too, like we use physical therapy and we use some stimulators on the back itself to help the pain of patients like this. If none of these conservative measures help him, and we have tried everything,
right,
then we can always convince the patient, look, we have tried everything, you have tried everything, now is the best time to go back to the neurosurgeon and see what he can do. If he is offering surgery, maybe that's the next thing to do.
Do you ever have cases where it's the opposite, where maybe someone has anxiety or depression enough where they're giving themselves pain? Because I know, you know, if you get upset enough, you can have stomach pain and stuff. How do you figure it out when you really... when someone's actually making themselves sick?
That's not a very common thing.
Okay.
So you're talking about hypochondriasis, somatization disorders.
Yes.
These are some of the diagnoses that we come across among some patients who have certain psychiatric illnesses that shows up as pain, or they're as you said, you know, it may not be really objective pain. It may not be really a body injury or a pathology. So we always make sure that we put the patient through certain investigations. Majority of the times, by the time the patients come to us, they would have already undergone MRIs, CT scans, electromyography, nerve conduction studies, and all these things. That will already show all the pathology. There are patients who have had MRIs which show severe degeneration in the spine. In that patient, we don't have to assume that, oh, this may be the depression causing the pain. No, we already see so much degeneration there. And there are so many different ways we evaluate the patient. It takes almost an hour to evaluate a new patient. And we put them through a thorough physical examination. All these things that we see in a patient tell us whether it is a real real problem, or if it is just the patient is suffering from some other disorder that is showing up as pain.
Right. Okay.
And first we make sure of that, and after that only we start offering these procedures and medications.
Okay. And you know, the gentleman that called in, Danny, said he had been on medication for so long. I would imagine that's not the best route. I mean, how long can you stay on medication until it's just no longer effective?
So, yes, this is a pain that has been there for like 18 years, he said.
Right, it's a long time.
So it's a very long, I mean, I'm sure he didn't have pain all 18 years constantly. I mean, it probably came and went initially, you know, he had on and off pain, intermittent pain, and then over the years it became constant pain. So we have various ways to manage that. We have certain opioid medications, non-narcotic medications, which help even in the long run. And there are opioid medications which we use in lower doses, but we keep rotating them so that the body doesn't get used to the same medication. We have something called neuromodulation, in which we implant nerve stimulators into the back, which has nothing to do with medications. It just stimulates the spinal cord.
Oh, wow.
That is one of the advanced procedures that we have, that we do in our center too, wherein we just stimulate the spinal cord with electrical leads. This can send vibratory signals to the brain and cut off the pain signals to the brain.
Oh, wow.
So this is also extremely useful in a large number of patients who have nerve-related pain. So we also implant pumps wherein we can directly deliver the drugs that we need directly to the spine. Instead of taking it by mouth and expecting it to spread all over the body and reach the spine, we can inject like 100 times less dose, 100 times less dose of the same medication, and inject it directly into the spine through a pump. and get a better relief. So we don't have, the patient need not be on a ton of medication. He can take like a few milligrams a day and get better relief. And through the pump, we can also send in medications that are non-narcotic, like baclofen, local anesthetic, muscle relaxants.
Oh, wow. Okay.
And these things can also help this pain that has been there for a very long time.
Okay, good stuff. We have a lot of phone calls coming in. If you have a question for the doctor, give us a call here at 737+, and we'll be right back. We'll take some of your calls.
Medical Mondays is brought to you by Nashville Pain Center.